Thank you, Ramu. I always look forward to being here. Thank you very much. It's become part of my March travel plans for the last 15 years. What I'm going to do over the next 20 minutes is to discuss with you a little of the advances in managing bleeding and clotting disorders. These are my disclosures. I'll talk a little bit about gene therapy beyond sickle cell disease, although I'll make some comparisons. I'll talk a little bit about thrombocytopenia, autoimmune thrombocytopenia, etc. But what I'd like to start off first is a discussion of what has actually become extremely exciting in the area of hematology, because this is going to form the basis for the treatment of many of the hereditary point mutation diseases that we have in the hematology sphere. But I can tell you that there are now over 500 protocols awaiting FDA approval for gene abnormalities and gene therapies. I'd like to start off talking about the issue of hemophilia. All of you are familiar with the idea of being able to perform gene therapy by taking, in this case, either a factor 8 or factor 9 gene, encapsulating it into a transgene, and then using stealth missile technology, essentially. This takes the DNA, the factor 8 or factor 9 gene, into the hepatocyte, goes into the nucleus of the hepatocyte, and then is transcribed with a messenger RNA so that the hepatocyte of the hemophilia patient is now producing factor 8 or factor 9. Now, the problem with this is that the transgene is an associated adenovirus as a vector. If you've had adenoviral infections in the past and you have antibodies against adenovirus, this may not be the best way to perform gene therapy, and that's been one of the limitations. Let's take a look at some of the results over here. In the hemophilia sphere, it's important to remember that we can do gene therapy without myeloablation. This will be very different from the talks that you'll hear perhaps about sickle cell and thalassemia gene therapy. We don't need to do myeloablation. We can put this gene into the hepatocyte, but we don't integrate into the DNA. These are episomal. And therefore, you can see in the factor 8, there are now 3 or 4 gene therapies available for hemophilia A now. These are all episomal, and you can see that although the patients have a very robust initial response with factor 8 production, you can see that the durability of that response dissipates over time. This has made it very difficult for commercial gene therapies to be accepted by insurance companies, etc. And even though we've got 3 or 4 gene therapies, including hemophilia B and these 3 in hemophilia A, there have been maybe only a handful of commercially financed gene therapies in the US since these have come out. The insurance companies just don't pay for them, and this has become a real issue for us in the hemophilia area. Compare this lack of durability to the patients who have hemophilia B and who have received their gene therapy. You can see that the durability is maintained in these individuals with gene therapy. So what's the difference? Well, the difference, I think, is the fact that the hepatocyte does not produce factor 8 normally. We're forcing the hepatocyte to produce factor 8. In fact, factor 8 is normally produced in endothelial cells within the liver, not the hepatocyte itself, whereas factor 9, being a vitamin K-dependent clotting factor, is manufactured in the liver. This is a natural recognized protein by the liver, and the durability, even though this is episomal, seems to be preserved. Now, one of the problems that we have in gene therapy for A and B is that we can't predict in advance what the response of the patient is going to be. Is it going to be low, medium, or super therapeutic? And in the hemophilia A situation, we've seen several individuals who have actually developed hypercoagulability responses after their gene therapy, and we've actually had to put some of these patients on anticoagulation in order to keep them from developing thrombosis. Amazing. A bleeding patient, gene therapy, now hypercoagulability patient. But this is one of the issues that we have with this particular episomal approach. We also have to always be worried about the fidelity of these transgenes, and are we going to be producing oncogenes with gene therapy? In our hemophilia population, as you can see here, there have been individuals who have developed malignancies, but we don't believe that these malignancies are due to the gene therapy because, well, first of all, we see a number of patients with hepatocellular carcinoma. Many of these patients have had hepatitis C. We know that those individuals have a risk of hepatocellular carcinoma. We don't know, however, whether or not we're accelerating the development of hepatocellular carcinoma with gene therapy. So much more to follow in the future with gene therapy. So what can we do to improve the efficiency of gene therapy? I'm talking now about gene therapy 2.0 in the treatment of the hemophilias, but this is going to be, I think, sort of a spread, an epitope spread into all areas of non-malignant hematology. You're going to be seeing what the CRISPR-Cas9 approaches to gene therapy. We've begun in our center a study, actually, which have evolved from some of the work from Cindy Dunbar at NHLBI, taking a look at the ability to collect B lymphocytes by apheresis, taking these patients' lymphocytes, isolating them, doing CRISPR-Cas9 gene editing ex vivo, and then infusing these B lymphocytes, which evolve into plasma cells and produce factor VIII or factor IX. By virtue of being plasma cells, we can freeze these away so that we can always reinfuse if the patients lose their genetic signals. This is then avoiding the AAV antibody issue, and I think this is what we're going to be seeing in the very near future. Well, let's move on to several other diseases that were presented at ASH. One is the question of ITP. So all of us who take care of ITP, when the patient walks in the room, we have to make a decision as to what kind of corticosteroid protocol that you're going to begin. So in the past, it's always been the prednisone 1 milligram per kilogram, and then some of the Italian studies suggested that using high doses of dexamethasone may actually be much more effective in the initial treatment of ITP. So please look at the top right-hand side of the slide where you can see the comparison of the responses, the initial and the durability of the responses to prednisone 1 milligram per kilogram for 4 weeks with a 2-week taper versus dexamethasone in this particular study, 40 milligrams daily times 4 days, every 2 weeks times 3 cycles. Now, the Italian group has shown, and in this randomized controlled trial, you can see that the dexamethasone individuals had a much more rapid initial response. However, the durability of the response was maintained in those individuals who had received prednisone initially rather than dexamethasone. So I would say that right now in my own practice, I only use dexamethasone, I might add, but I'm pushing all of the second-line treatments of ITP into front line. So I do not use rituximab. Rituximab, although it's been effective, has long-term consequences in these adults, primarily CVID-like illnesses and immunosuppression. They don't respond to vaccines, for instance. I have been moving the TPO receptor agonists into the front line. Those agonists have shown robust and durable responses over many years now, 5 years at least. And I think that that's what we're going to be seeing is the movement of second-line treatments into the front line. Just to indicate to you how active this field is, you can see on this cartoon with all of the numbers, the various areas that you can actually target to treat ITP. And whether it's the destruction of B cells the interference of the antibodies against the glycoproteins on the surface of the platelet, whether it's to interfere with macrophage phagocytosis using the Syk kinase inhibitors, or whether it's using some of the Bruton tyrosine kinase inhibitors, which are now becoming more popular. There are many ways of treating this, including splenectomy. And the problem is that ITP is a disease of thirds. So approximately 2/3 will respond to almost anything, but then you've got a third. And those are the individuals, those refractory individuals, where the second-line therapies are critical. And just to give you an example of what is emerging in ITP, this is just some of the drugs that were discussed during ASH this year. And whether it's an anti-CD38 monoclonal antibody like daratumumab is coming into the treatment of ITP after plasma cell dyscrasias. We have BAFF pathway inhibitors. We have the BTK inhibitors. We have the Syk kinase inhibitors and the FcRn2 antagonists. Where is this field going to end? Because not everything is going to be useful in the ITP area. It's already too crowded commercially. I think the FcRn receptor antagonists have been very useful. Efgartigimod is very useful. So essentially, we have a system of FcRn receptors in our hepatocytes which allow the recirculation of IgG in the circulation. If you antagonize that mechanism, you actually reduce the recirculation of IgG into the circulation and thereby reduce the amount of IgG which will coat the platelet and increase platelet destruction. Now, efgartigimod was presented not at last year's ASH, but the year before, showing how effective it was in those individuals who were refractory to the first-line therapies of ITP. You had approximately a 30% or more response. This was an IV administered drug. Unfortunately, the subcutaneous form of the drug failed, and therefore the company pulled the drug off. But now there's hope that we can get the drug back in as an IV-administered drug for treatment of refractory ITP. But interestingly enough, at ISTH, there was another drug called mezagitamab. This is a monoclonal anti-CD38 drug for ITP. You can see again that there was robust response in reducing CD38 positive lymphocytes, B lymphocytes, and it appeared to be a very nice, robust response. There are other drugs that have been discussed, the Bruton tyrosine kinase rilzabrutinib. You can see that this response also looks extremely robust. I think that this will be the next drug approved by the FDA. Interestingly enough, this BTKI is not associated with bleeding complications as other BTKs are, and don't have the same pancytopenia effect of many of the other BTKIs. I want to also now jump to a bleeding disorder, because I think this is very important for all of us as clinicians when we screen individuals for von Willebrand disease. In this study, African American women, adolescent women with heavy menstrual bleeding were screened for the diagnosis of von Willebrand disease. This is a very common approach to the diagnosis of heavy menstrual bleeding. And in this study, lo and behold, there were a number of women who were diagnosed with von Willebrand disease using the ristocetin-based von Willebrand factor activity assay, which is typically present in all of our coagulation laboratories. Well, ristocetin is a very capricious molecule. It can't be standardized. It's not standardized by the FDA. These assays can often have other problems associated with the assay. Essentially, in this study, then, using a different kind of ristocetin receptor assay, where we're looking at the GP the glycoprotein 1b9 interaction with von Willebrand factor, rather than trying to induce that interaction with ristocetin, you can see that many of these women did not have von Willebrand disease, but they had a genetic mutation in the portion of the von Willebrand factor gene that interacted with ristocetin but did not interact with the GPL1, the glycoprotein 1b9 complex. So the important thing here is to know what assay your laboratory is using when you're diagnosing von Willebrand disease, particularly in African American or African women, because over 50% of those individuals will have a specific gene mutation in the part of the von Willebrand factor that will produce a false positive rate. These women then have been treated for von Willebrand disease and they don't have it. Those individuals with the gene mutations do not have von Willebrand disease. They will not bleed with surgery, and up to now these women have been indiscriminately treated as if they did. Now, in view of the time constraints, I want to move on then to another important study. As you know, we've been using DOACs for the treatment of venous thromboembolism for years. And studies have, over the last several years, have shown that you can actually use dose-reduced DOAC drugs, such as Xarelto and apixaban, for instance, at 2.5 milligrams BID or 10 milligrams daily, and not have any decrease in efficacy and improvement in bleeding overall. But we never had any long-term studies to show whether or not the one-year results that had been published can be maintained over a long period of time. In this study, in this randomized study from Europe, individuals were on low dose versus conventional dose DOACs over a 5-year period of time. And you can see from the graph on the right-hand side that there was a reduction in the bleeding complications in these patients over 5 years. This was statistically significant. You can see 16.5 versus 11.8. And there was no loss in efficacy with the VTE incidence of 2.2 in the reduced dose arm versus 1.8 in the full dose arm. And with that, I will discontinue what I'm talking about, but I just want to make a 10-second comment. The glucagon-like peptide receptor agonists, the newest, most popular drugs now available, these drugs appear to be able to reduce the incidence of venous thromboembolism in high-risk patients. You're going to be seeing this drug used in cocktails coming up in the near future. With that, I'll stop and thank you for your attention.